Good morning, my honored audiences and professors. My name is Possawat Wanlopworakit. I'm from the Pediatric Department, College of Dental Medicine, Longsit University. Today, I would like to present my research in the topic, clinical performance of high viscosity glass ionomer restorations in pulp-treated primary molars to 12-month results. The main topic today will be divided into 4 parts. First, I would like to point out that the key to success in pulp treatment in primary molar is that the restorations should have adequate sealing efficacy and able to function in oral cavity until its exfoliation. At the present day, the gold standard or the most effective long-term restoration for pulp-treated primary molars is the stainless steel crown or ASCs, because ASC is the full coverage restoration which can protect the weakened cavity walls and it can prevent marginal micro leakage. It also has good durability and longevity and require minimal maintenance. However, there are still some disadvantages of ASC that need to be concerned, including gingival bleeding, aesthetic concerns, risk of aspiration and ingestion, ionotic damage, and it requires significant amount of tooth preparation and clinician skill. Therefore, many previous studies try to find the alternative restoration for pulp-treated primary molars. Guman's study in 2005 suggested that if there is sufficient supporting enamel remaining, amalgam or composite resin can provide a functional alternative when a primary tooth has a lifespan of 2 years or less. In previous randomized control trial of 2-year survival rate between ASCs versus modified open sandwich restoration for primary molars by Etienne in 2008, he found that there was no statistically difference in 2-year survival rate of ASC and modified open sandwich restoration. However, Etienne gave some consideration for using modified open sandwich technique is that it is highly technique sensitive, and for pediatric dentistry, it requires patient compliance and adequate moisture isolation, and it's also increased expense time and material. Most of glass ionomer restoration which being used in the present day have been classified as from the chemical composition into 2 types, high viscosity glass ionomer cement or HVGIC and resin modified glass ionomer cement or RMGIC. In our research, we focus on the HVGICs. The HVGIC still remain the HVGIC still remain the advantages of conventional glass ionomer cement, and it also has increased physical properties, no sensitive technique, and can be placed by ball filling technique. There was a study that compared the strength of the amalgam restoration with the ART and HVGIC restoration, and in this prospective clinical study, the survival rate were no difference from the comparative conventional amalgam restoration. As of today, there is no clinical study about using HVGIC restoration in pulpotomyces or pulpectomyces primary molars. Therefore, our research questions were, can HVGIC be used as the definitive restoration in pulp-treated primary molars without compromising the long-term success of the pulp treatment? And our objective is to investigate the clinical performance and the survival time of intercoronal technique using HVGIC in pulpotomy and pulpectomy treated primary molars. Research methodology. Our sample were the healthy children aged from 3 to 11 years, which had one primary molar that required pulpotomy or pulpectomy, and the tooth must be restorable with intercoronal technique. The inclusion criteria are the teeth that was diagnosed as deep dental caries to pulp necrosis with acute or chronic apical abscess. The prepared cavities were classified into 2 groups. The first ideal cavity are the teeth that has the extension without extension beyond lingual, and the less ideal cavity is the tooth with the extension beyond lingual. Our exclusion criteria are as shown. The process of pulpotomy and the process of pulpectomy are followed by the standard protocol from our pediatric department as shown in the presentation. After the root canals were filled, the coronal pulp space was filled immediately with the reinforced single-site eugenol base or IIM. And after the coronal pulp space was filled, the conservative cavity preparation were performed. Then the clinical cavity walls must be smooth, clean, and sound surfaces. The prepared cavities were applied with dentine conditioner, then rinsed and dried. The prepared cavity surfaces should appear moist and glistening. The study teeth were immediately restored by Fuji 9GP Extra as the definitive restoration with ball filling technique. The finishing was performed using enhanced finisher and the restorations were protected with GC Fuji varnish. Our research was approved by the Ethics Review Board of Rangsit University. Measurement and statistical analysis. For outcome measurements and clinical evaluation, we use two independent evaluators that were calibrated using Cohen-Kappa test. The evaluation was divided into clinical examination using visual inspection and data probe, radiographic examination using peripheral radiograph. The sample size was calculated using the sample size of previous studies and was adjusted about 15% in case of lot of follow-up, and therefore we need 40 cases in our study. The first hypothesis, there is no statistically significantly different in clinical outcome between baseline and the recall period after 6 months and 12 months respectively of HVGIC in pulp-treated primary molars. The clinical outcome were judged as failure if the tooth has failure using the clinical failure parameter, including both pulp treatment failure and restoration failure. The comparison in clinical outcome of HVGIC restoration were performed by visual exact test with the level of significance P equal to 0.05. The second hypothesis is that there is no statistically significantly difference in clinical performance between ideal HVGIC and less ideal HVGIC restoration in pulp-treated primary molars. The clinical performance were evaluated using modified Rice criteria, which were contain 5 categories: marginal discoloration, enamel loss, secondary caries, anatomical form, and marginal adaptation. The score were ranked into three scores: alpha and beta, which considered to be favorable, and Charlie considered to be unfavorable. The comparison in clinical performance of HVGIC were performed by using different tests with the level of significance P equal to 0.05. And the last topic, we performed the survival analysis using Kaplan-Meier survival analysis to compare between ideal cavity and less ideal cavity HVGIC restoration. The time were measured from the day the tooth were restored until 1 year, or if any events happened. The events are including clinical or radiographic failure, study tooth was exfoliated, or loss follow-up of the patient. The event was used as the event was used at the endpoint of that tooth. Result: there were 39 children with boy and girl ratio equal to 1.67 and with a mean age of 7 years and 8 months, SD equal to 19.6. 36 children had 1 study primary teeth and 3 children had 2 study teeth. Total of study teeth is 42 teeth. The inter-rater reliability, the Cohen-Kappa coefficient was 0.85, which is considered to be acceptable. The overall success rate was statistically different between baseline and 12-month follow-up period, with the level of significance P equal to 0.018. The overall outcome was 100% at baseline, but was reduced to 90.5% at 12-month follow-up period due to 4 of the study teeth were failures. From 4 of the failure teeth, the teeth were only found with restorative failure without any pulpal failure. And the first 3 restorative teeth were found as favorable outcome at baseline. 2 of them were found at failure at 9 months, and 1 of them were found as failure at 10 months. The another one of the restorative failure tooth, the tooth was found with the radiographic marginal defect without clinical defect at baseline until 12-month recall period. The marginal gap was clinically detected and was judged as restorative failure. Next is a comparison of clinical performance between ideal and less ideal cavity HVGIC restoration. There was statistical difference between ideal cavity and less ideal cavity restoration in restorative success at the end of 12-month follow-up period, with the level of significance P equal to 0.035. The first category is the marginal integrity assessment. At 12-month result follow-up period, the difference were found between both groups with the level of significance P equal to 0.035. However, tooth integrity assessment, secondary caries, were an anatomical assessment. At the 12-month follow-up period, the difference were not found between both groups. The 1-year survival analysis of both groups found that the mean survival time of ideal HVGIC restoration is 12 months, and the mean survival time of less ideal HVGIC restoration is 11.6 months. This is the distribution of favorable restorative teeth regarding the tooth, cavity type, and dentition. I would like to point out that most of favorable teeth were second primary molars, which equal to 84.2%, and most of those second primary molars were in mixed dentition, which equal to 76.3%, whether it was ideal or less ideal cavity group. and discussion. Adhesive restoration taken interested as an alternative restoration for pulp-treated primary molars due to it can preserve the sound tooth structure and it can offer a normal contact area and enhance resistance to marginal microrichet. According to previous randomized control trial of 2-year survival rate, the success rate of modified open sandwich restoration was 92.5%. Moreover, in a prospective randomized study of 1-year survival rate of class 2 adhesive restoration in pulpectomized primary molars, the highest survival rate was found in resin composite restoration, which was 93%. In our 1-year result, the restorative success of HVGAC. In our 1-year result, the restorative success rate of HVGAC restoration in primary molars after receiving pulp treatment was 90.5%. Our result was coincide to the previous study that we had mentioned before. From 1-year result, the high success rate of HVGAC restoration in pulp-treated primary molars were frequently found in the second primary molar, which were in mixed dentition. The researchers suspect that in permanent dentition, the first primary molars is the main functional tool to support occlusal forces and lead to an improvement of the survival time of the restoration. Interestingly, from 1-year result, the restorative failures were not found in the both ideal and less ideal HVGAC restoration of the second primary molar, which were in mixed dentition with erupted first primary molars. According to Kaplan-Meier survival analysis, this 1-year survival time of HVGAC for both ideal and less ideal HVGAC are 12 months and 11.6 months respectively. Our 1-year result is coincide to a 1-year survival time of modified open sandwich restoration in pulpectomized primary molar from ATS study. Conclusion. HVGAC may be used as an alternative restoration for restoring pulp-treated primary molars when the primary tooth had a lifespan of 1 year or less and ASC is not indicated. And HVGAC can be either used at final restoration or long-term immediate restoration in pulp-treated primary molars. However, this study requires a longer follow-up result and significantly sufficient sample size in order to obtain the more accurate outcome about clinical performance of HVGAC in pulp-treated primary molars. Thank you.
Thank you for your presentation. Very good, nice. Nice. Okay. Anyone, if you have question, you can ask him. Please.
I have a question. Is effect of GI as good as the ASC and why?
In the practice, the gold standard is still the ASC restoration. However, we offer the alternative treatment in case we can't use the ASC, because as from the other result, the strength of ASC and the HVGAC restoration is considered to be comparable if the tooth has a lifespan of 2 years or less. So I think if the primary tooth or the primary molar that use if the primary molars that has a lifespan about 2 years or less, and you can use the ASC restoration due to some considerations like patient doesn't have patient compliance and it's hard to finish the job in one visit, you can consider to use HVGAC restoration because it's easier to complete the treatment in one visit. Yeah.
Okay. Is anyone have any questions?
So I have one question. So thank you about your good presentation, but I have some questions. So do you have an information of using HVGAC in permanent molar tooth about the success rate? Thank you.
I am sorry, we still don't have the data about using the HVGAC in the permanent molars.
Is there any information in the literature, other research?
Sorry?
Is there any information in the other research article?
from our literature review, we only focus on restoring the primary molar. So we didn't actually do the research about using HVTIC in the permanent molar tooth.
Okay, thank you.
Okay, is there any questions? Thank you very much, Mr. Possawat, thank you for the presentations, and thank you, audience, for your wonderful questions.